The next learning objective is explain the pathophysiology and clinical presentation of Pneumocystis pneumonia, Toxoplasma, gondii encephalitis, and Mycobacterium avium complex disease. Pneumocystis pneumonia, or PCP, is actually caused by Pneumocystis jirovecii, which is actually a fungus species. So PCP, which some people call PJP because of this change in nomenclature. So it used to be, PCP, the C used to stand for Carinii, but because it was, the taxonomy was changed, you may see the abbreviation PJP. But in general, the DHHH guidelines still refer to it as PCP. Now, because this is ubiquitous, it is thought that we all get exposed to this organism as a, during our childhood, and immunosuppressed patient, it basically gets reactivated, and in HIV specifically, it can lead to the infection of the lungs and pneumonia. And 90% of PCP cases occur when the CD4 cell count is less than 200. So this is an important cutoff to remember, CD4, less than 200. Also, patients who do not have HIV, but they are on prolonged use of systemic corticosteroid, so typically at least 20 equivalent milligram of prednisone for at least 4 weeks. These patients will also be at risk of PCP, because corticosteroids can also reduce the CD4 count. Now, transmission is person to person, so obviously healthy people can be colonized with this. It just doesn't cause an infection in an intact immune system, but immunodeficient people will actually develop the pneumonia. Now, when it comes to the host defenses, there is innate immunity, so alveolar macrophages as well as surfactant proteins protect individuals from this organism, as well as humoral immunity. So T cells, B cells, and immunoglobulins from the B cells are involved, which explains why patients with compromised T cell are at increased risk of getting PCP. So the clinical manifestations include exertional dyspnea as well as fever, non-productive cough, and chest discomfort, which worsens within days to weeks. Now, this is a progressive disease, so the prodromal period can extend from 3 to 8 weeks. So in general, for any infection, the initial phase is the incubation period, followed by prodromal period where you have mild signs and symptoms, and then you have a period of illness followed by a period of decline, as well as a period of convalescence. So in PCP, in HIV patients, this prodromal period could be very extended, 3 to 8 weeks. So it's very progressive. So for definitive diagnosis of PCP, histopathologic or cytopathologic demonstration of the organism is in either tissue, BAL fluid, or induced sputum sample is required. If you have chest radiograph, so technically, basically chest X-ray, you will see symmetrical ground glass infiltrates. On chest CT, you will also see the same. The benefit of chest CT is that even if the chest X-ray is normal, you can still see the ground glass appearance on the chest CT. PCR is an alternative method. It's alternative because it's expensive, and it's also cannot distinguish between colonization and infection. And there's also the B-glucan test, which is highly sensitive but low specificity. So if it's positive, it doesn't necessarily mean PCP. It could be any fungal infection. But if it is negative, then you can rule out PCP. And lastly, one observation is that lactate dehydrogenase typically happens to be greater than 500 in patients with PCP, but that's non-specific. So, this is not really for diagnosis. It's It just gives you a clue if you see a high lactate dehydrogenase. Let's change gear to Toxoplasma gondii. So toxoplasmic encephalitis, or TE, is caused by Toxoplasma gondii. It is a protozoan parasite. So you can see that in the life cycle of this parasite, cats are involved as well as livestock. So, you know, the risk factors for getting this would be basically undercooked meat as well as raw shellfish, so oyster, clams, etc. As well as, you know, if you have exposed vegetables, so untreated water or, you know, organic food, or if you're growing your own food and cats are, or even livestock are around these, that could expose the patient to Toxoplasma gondii. Now, this is opportunistic infection, so people with an intact host immunity don't have to worry about this, but this is for people with CD4 count less than 200 that are at risk. So clinical manifestations include focal encephalitis with headache, confusion, or motor weakness and fever. For diagnosis, it is important for all patients with TE to be tested for Toxoplasma IgG because they will be seropositive. So Toxoplasma IgG will be positive. So if the IgG is negative, it's very unlikely that someone has toxoplasmosis. Now, definitive diagnosis requires 3 criteria. So a compatible clinical syndrome, so you know, the symptoms have to be there, and then identification of 1 or more mass lesions by CT or MRI of the brain, as well as detection of the organism in a clinical sample, typically brain biopsy. And this is really reserved as a last resort. In other words, instead of doing brain biopsy, if someone has Toxoplasma IgG, you know, you go ahead and treat them. It's really not necessary to go into brain biopsy. And lastly, Mycobacterium avium complex, or MAC. You know, there are multiple species of Mycobacterium, so not Mycobacterium tuberculosis, but we'll talk about that on another day. But these are more of a slow growing non-tuberculous mycobacteria, which several of them that are common in these patients are grouped together and called a complex. So because avium is the most common one, gets the name. So Mycobacterium avium complex is a group of multiple mycobacteria. Regardless, these are opportunistic infections that typically occur in people with HIV with CD4 of less than 50. So this one, you really have to deplete the CD4 cell counts in order to be exposed to this. We will discuss more about mycobacteria in general when we talk about tuberculosis on another topic. Symptoms include fever, night sweats, weight loss, fatigue, diarrhea, and abdominal pain. So you will see that these symptoms are also common in tuberculosis, night sweats, weight loss, as well as anemia and elevated liver alkaline outflows. For diagnosis, a confirmed diagnosis is based on compatible clinical signs and symptoms, as well as isolation of MAC from culture of blood, lymph node, bone marrow, or other normally sterile tissue or body fluids. Now, cytomegalovirus is widely prevalent herpes virus. It is a double-stranded DNA, and the primary route of transmission is by interpersonal contact via infectious body fluids, including saliva, semen, cervical secretions, as well as breast milk. Now, when somebody gets infected by CMV, it establishes latent infection in the host after recovery, just like all other herpes viruses. And pretty much more than half of the population is infected with CMV. Fortunately, there is no disease in healthy hosts, so it's pretty much asymptomatic infection in healthy individuals. Now, it does cause congenital CMV syndrome in neonates, which could be fatal for neonates. and it can cause infectious mononucleosis in young adults, essentially manifesting as fever, malaise, and myalgias. Now, the real problem is when we go from CMV infection to CMV disease. So, severe disease syndrome occurs in immunocompromised individuals, and that includes recipients of solid organ transplants. So, solid organ includes the lung, liver, kidney, and heart, as well as recipients of hematopoietic stem cell transplant, and patients with HIV and advanced immunosuppression. Specifically, a CD4 count of less than 50 puts these individuals at risk of severe disease of CMV. Now, what exactly is CMV disease? So, CMV can cause retinitis in the eyes. It can cause colitis in the GI tract, esophagitis also in the GI tract, and pneumonitis and neurologic disease. The most common in individuals with HIV is retinitis. And this really up to 30% in individuals not receiving ART. In the era when individuals are receiving ART, it's really not as common anymore. And it's followed by colitis, about 5 to 10% of individuals. And then esophagitis in a very small percentage. Pneumonitis is very uncommon. Now let's take a look at some of the symptoms. With retinitis, basically, patients will experience floaters, which essentially means spots in the vision, scotoma, and the plural for scotoma is scotomata, and it essentially means a partial loss of vision or blind spot in an otherwise normal visual field, and of course, peripheral visual field defects. And diagnosis is done by an ophthalmologist through eye examination. Patients with CMV colitis experience weight loss, fever, anorexia, abdominal pain, diarrhea, and malaise. And it can be severe if it causes hemorrhage and perforation, which can be life-threatening in patients.